From the JAMA Network, this is JAMA Cardiology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA Cardiology.
Hello, and welcome to our listeners from around the world. Welcome to the JAMA Cardiology podcast. I'm your host, Dr. James Udelson, Chief of Cardiology at Tufts Medical Center in Boston and an Associate Editor of JAMA Cardiology. I'm joined today by Dr. Jwan Naser, a first-year cardiology fellow at Mayo Clinic, and Dr. Barry Borlaug, also from the Mayo Clinic in Rochester, Minnesota. We're going to discuss their paper being published in JAMA Cardiology, Prevalence of HFpEF in Isolated Severe Secondary Tricuspid Regurgitation. Jwan, welcome.
Thank you very much.
And Barry, welcome to you.
Thank you, Jim.
Jwan, maybe you can start. I'll ask you, just give us the big picture here. What interested you both in trying to investigate this topic?
Absolutely. So we've been very interested in isolated or idiopathic secondary tricuspid regurgitation, or TR, which is essentially secondary TR without hemodynamically significant left-sided valve disease and in patients with normal ejection fraction. So this concept of isolated TR has been recognized and utilized really for years, but with limited understanding of underlying etiology, which is really essential to allow the management of TR. So what we did is we studied patients with isolated severe TR who had invasive hemodynamic assessment, both at rest and exercise, in order to assess the prevalence of underlying heart failure with preserved ejection fraction, or HFpEF, and also precapillary pulmonary hypertension, and then also evaluated the performance of non-invasive tools, such as diastolic function parameters and measures of left atrial function in the identification of HFpEF.
So Barry, one of the key parts of this study is how you defined HFpEF, when people come in, obviously, with a certain kind of volume overload to begin with. So how was it defined in this study?
Yeah, this kind of gets at the core of the issue, because if you go to somebody who is an imager and they see severe TR, they say, oh, this is severe TR. Or a structural specialist in the cath lab, they call it severe TR if you have dyspnea and TR. But if you go to a heart failure doctor and you see TR, you're like, that's probably tricuspid regurgitation due to heart failure. And we need to have a gold standard, an arbiter to say that this is HFpEF, and it is not. And, the gold standard is with hemodynamics. So directly measured pulmonary wedge pressure is a surrogate for left atrial pressure. So if the wedge pressure was elevated at rest, 15 or higher, or 19 or higher with passive leg raise, which has been shown to correlate with exercise, or a wedge pressure of 25 or higher with exercise. And these are all accepted by current guidelines as being the definitive gold standard to establish whether HFpEF is present. So that's what we used for our case definition.
Excellent. Okay, so now the prevalence of HFpEF in these patients. Tell us what you found.
Absolutely. Yeah, we had some very exciting findings. So we found that among 54 patients with severe isolated TR, 74% had invasively diagnosed HFpEF, which was recognized before invasive hemodynamic assessment in only half of these patients. And then in patients without HFpEF, 71% had precapillary pulmonary hypertension. So most of the patients had an underlying disease that can be targeted with specific therapy beyond TR-specific intervention. And only the minority of patients had isolated right atrial or ventricular myopathy.
So interesting. And just can I follow up? What do you mean by prior recognition? These are people who were thought to have HFpEF beforehand?
Yes, those are patients who were recognized and diagnosed with HFpEF before referring to right heart cath.
I see. So Barry, one of the objectives was to examine how useful echocardiographic diastolic dysfunction parameters were. What did you find in that regard?
Yeah, we saw that the ASE criteria for diastolic dysfunction, which date back to 2016, I believe, focusing on transmitral Doppler, EE prime, LA volume, and tricuspid regurgitation velocity as a measure of PA pressure, it was very insensitive. It was only 40% sensitive, so it missed 60% of the cases. So what we've been relying on in the past was not working well. But we've seen in other cohorts where we compare HFpEF to patients with non-cardiac dyspnea that measures of left atrial form and function, and in particular, LA strain, was much better. And the area under the curve for LA strain, LA reservoir strain, and LA emptying fraction, which is a lower tech version of that, was very good, like 0.9. So that was much more robust to discriminate these people that had severe TR owing to HFpEF versus not HFpEF.
You think, Barry, it's time to abandon those ventricular diastolic parameters and really focus more on the left atrial parameters, which I think you've shown several times now?
Yeah, I think maybe abandon would be a stronger word than I would say, but I do think that they need to be downgraded quite a bit. I think that, a lot of the action is in the left atrium, and that really time and time again in all of these papers that we've been looking at where we have invasive hemodynamics and simultaneous echo, that's the one that always stands out as the best, are these measures of left atrial function.
And it may be, Barry, that your lab over the years, so few of these studies in the past with the echo parameters really had the gold standard of rest or exercise hemodynamics. Maybe that's the difference.
Yeah, I think so.
So, Jwan, one of the aspects of this that was most interesting to us was that, this was not just kind of an exercise in, understanding pathophysiology, but some real management implications here. Can you talk about those, uncovering someone who actually has HFpEF?
Absolutely, yeah. So we had some important actionable items here. First, the fact that most patients with isolated severe TR had an underlying disease that can be targeted with specific therapy, including HFpEF and precapillary pulmonary hypertension, really underlines the importance of taking a step back and looking beyond TR for the underlying cardiac or pulmonary process before, or at least side to side, to the now approved transcatheter tricuspid valve intervention. The second point is that relying on guideline-defined diastolic dysfunction, as we have talked about, or even the presence of pulmonary hypertension on echocardiography to suspect HFpEF is inadequate and will result in missing a substantial number of those patients who can benefit from currently proven effective therapy, including SGLT2 inhibitors and potentially GLP-1 agonists as well. Finally, all 8 patients who had COPD in the study actually had HFpEF, which kind of raises the point that the presence of lung disease should not preclude such suspicion of HFpEF or evaluation of HFpEF.
Right. That's another very important message that came through here. My last question, Barry, back to pathophysiology for a moment. Is it interesting in the discussion about the underlying importance of ventricular interdependence here? Can you talk about that a little bit? And, where do you see that fitting in as part of the underlying problem?
Yeah, Jim, that's a really great point. And a lot of us think about left heart filling pressures as just being determined by, the compliance and relaxation properties of the left heart. But of course, the right heart influences the left across the septum and then abuts the pericardium on the other side. And we call that extrinsic restraint, and pericardial restraint. It leads to ventricular interdependence. And a lot of people with HFpEF have a greater role for this extrinsic restraint. So what that does is by pressurizing the left ventricle and left atrium from the outside, that drives up the filling pressures out of proportion to the distension from within. And we do see that in patients with tricuspid regurgitation. And particularly people that fulfilled diagnostic criteria for HFpEF based on their resting wedge being elevated, these people tended to have more of that abnormality. But when we look for other indicators of sort of constrictive like physiology, like enhanced ventricular interdependence, we did not see that to be present. So it's not the same degree that you see with like pericardial constriction. And in fact, the ventricular interaction and the transmural pressure was even lower in the patients with TR in the absence of HFpEF. So those people, they didn't have as high of a wedge pressure or left atrial pressure, but they had a higher component that was related to this extrinsic restraint on the heart. So it is a very important part of the equation, but that's not the principal cause of elevated filling pressures in these patients on average. It's HFpEF, it's left heart disease. But it's the right heart remodeling and ventricular interdependence and interaction is a co-conspirator and something else that might need to be treated.
Well, that's a good way to put it. Well, congratulations to you both. As always, the studies that come out of your lab are incredibly comprehensive. And, here there are a lot of lessons about the importance of thinking about doing exercise right heart cath to uncover this physiology with the management implications and uncovering people who need to be treated. It's really, really interesting. And congrats. And Jwan, first-year fellow, first author publication in JAMA Cardiology. That's quite an accomplishment. So thanks so much to you both, and congratulations.
Thank you, Jim.
Thank you for having us.
And thanks to everyone for listening. This episode was produced by Shelley Steffens and Daniel Morrow at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or wherever you get your podcasts. A link to the JAMA manuscript can be found in this episode's show notes. Thanks for listening and for looking at their paper.